Good afternoon. I'm Nathaniel Osgood, and we're joined by Wade McDonald. We're jointly delivering this talk that provides an introduction to agent-based modeling with two notable examples of applying agent-based modeling, both within the communicable disease area. Within this talk, we are going to be first take a look at some basic characteristics of agent-based models, speak about some of the advantages of modeling in this fashion, but also some of the limitations. We're going to be talking about chickenpox and shingles example first, and then a pertussis example second. We'll end with some summaries. And Wade will be, since the examples come from his hand, he'll be taking the lead at describing them and in characterizing their goals and the types of agent-based models used to deliver them. So let's first talk about characteristics of agent-based modeling. Agent-based modeling is a computational or dynamic modeling technique which seeks to understand behavior of complex systems through the lens of agent-agent and agent-environment interactions. Understand behavior of a system as a whole that bubbles up from interactions at a lower level of agents, and often at multiple levels. We specify behavior of situated agents at one or more levels beneath, and these agents interact, and it dictates the emergent patterns, often surprising, that result over time, over space, over networks, at one or more levels of the system. And agent-based models, like other types of dynamic modeling, vary from the extremely stylized, very, very simple thinking tools, often for theory building, to descriptively rich and empirically grounded models that are aimed at theory explication, understanding the logical consequences of theory over time. So what are these agent-based models? Well, they consist of one or more populations of agents, each of which is associated with parameters, some state. So the parameters are sort of fixed assumptions, state, aspects of their situation which evolves over time, and actions that change that state over time, often specified as rules or rates of change, and rules that govern those actions. These models are specified over some time horizon and with either continuous or discrete time, for example. Agents in them critically are situated in environments, network environments, spatial, often geographic environments, sometimes spatial, non-geographic, sometimes more stylized, sometimes highly evidenced and empirically grounded. Beyond these, there's typically with these models some specification of outputs over time, which occur in the context of reporting on aspects of agent state. Sometimes those are governing factors in the model, but often they're just epiphenomenal factors reporting. And then finally, interventions, components that intervene upon a model. Now, we're going to go through each of those. So for parameters, we may have three parameters defined in the model. For example, a person's sex, their income, and their ethnicity. When we actually run the model, we'll get a whole profusion of people within a given population, perhaps. And each of those people is associated with particular values for those parameters. In terms of state, a person might be associated with, for example, state related to infection status, indicating that at any one time they are either susceptible, exposed, infected, or recovered. But over time, they evolve between those states. And the state chart at once depicts the states as well as the actions that can change state. For example, someone emerging from latency latent infection and becoming outright infectious or infective, or transitions associated with communication of illness or recovery. But the little icons hint to the fact that there's rules governing these actions, these things that change state. We won't go into that more, but there's a variety of types of rules. For example, hazard rates characterizing progression, or fixed timeouts, or occurrence based on an interaction from another agent. Now, importantly, when we think about these in the context of older types of aggregate dynamic models, we can represent at an individual level a given agent's state and its evolution over time with respect to more than one type of concern. So, for example, infection, or with respect to care seeking, with respect to vaccine attitude, perhaps, with respect to chronic diseases that serve as risk factors for infection. And we can represent this. A person is in a particular state for infection, particular state for care seeking, without needing to deal with a combinatorial explosion of possibilities, as we are dealt by the curse of dimensionality with an aggregate model, where stratifying leads to this profusion of different combinations, where the number of those combinations rises geometrically with the number of dimensions. And we can characterize, for example, in different state charts, different concerns, and still have them interact in ways that are defined, perhaps through surgical small interactions, but otherwise evolve fairly independently. And this can be done in a way that's very, very elegant compared to the cacophony of combinations that occur within stratified, and particularly highly stratified aggregate models. Now, importantly, these agents subject to these states, these agents with these parameters, are not solitudes. They are placed in an environment which situates them, and it situates them particularly commonly in networks, with connections with others, or in space. So with agent interactions, often we place the network in connections. And this is a reflection of the fact that agents in general, when they have parameters, characteristics or attributes, those can be continuous, something that really isn't possible with ODE-based aggregate models, with stock and flow models. You'd have to go to PDEs, partial differential equations. But they could be discrete, but they can also be relational attributes. And a person can have, for example, their presence in one or more networks: family network, collegial network, social network, intravenous drug use network, sexual network, for example. And we can place them in these network contexts. Now, typically these agents are placed in this network because that network serves as a conduit for interactions with each other, with one or more other types of agents, perhaps person-person, perhaps person community service provider agents, person physician, etc. And often this mode of interaction over the networks is achieved by messaging, by one agent sending messages to the other. And these can be handled in many ways that I won't get into, but it provides a very flexible and, in fact, rather computationally elegant way to characterize agent-agent interactions along one or more networks. Beyond networks, though, we commonly place agents within spatial context. By no means in all models, but in many models. And there's many motivations for this, placing them in an irregular environment or a 3D environment or a stylized environment here, a geographic environment. We can capture things, locality perception and influence, aspects of social determinants of health, the presence of food deserts, for example, or underserved areas that are underserved by healthcare provision, or the longer testing delays in some regions. Perhaps we're interested in behavior that is actually spatial in nature, like walking, coming from investments in walkability or support groups for walking. Or we're interested in the sort of disparities that occur in the clustering of unvaccinated people or individuals at high risk of infection because of high chronic disease burden that cluster together. And we can capture the disproportionate risk of infection in those regions using tools like this. It isn't so much that there's some average impact of this, it's that often there are pockets where you can have outbreaks where you'd never think there could be outbreaks given vaccination rates, for example, as a whole. Often we seek to understand interventions within space, or because we want to provide interventions that aim at changing the spatial environment for extra service provision, providing supermarkets, for example, or healthcare services in certain regions. Now, these models, when they're run, a key need is to understand their behavior, and whether it's governing factors in the model that we output or more epiphenomenal factors that, say, summarize the model but don't drive it. We often are keenly interested in the outputs and the resulting emergent behavior. And sometimes those emergent behaviors can be quite eye-opening. Commonly, there are behaviors over time, like we might get from an aggregate model, but very commonly there are behaviors over space, or behaviors over networks by which infection or risk concentrates in certain areas of our network. And sometimes these patterns can be key for understanding the dynamic seen in the behavior over time, because, say, if the concentration of risk of exposure to prions in areas near the water margin as shaping infection risk that then plays out with unexpected impacts on the population over time. Now, when we depict factors at an individual level, it's typical that we are dealing with spheres of human behavior, psychology, risk that are stochastic in nature. Whereas with aggregate models, often we as George Richardson is saying, abstract away a certain amount and focus on broad patterns. Within these models, we're dealing with individual events like exposure to infection or recovery. The event associated with care seeking, or an event associated with decisions as to where to seek out sustenance, food. And as a result, these models, these state charts that we saw, are commonly characterized by stochastic evolution. And that has many advantages. It often allows us to explain variability we see, for example, in real-world data. But it does place an obligation on us, an onus on us, to ensure that model results are not merely flukes that came from one chance event, a series of events in a model, but instead reflect regularities and orderliness in the results that is replicable. And in order to achieve this, we typically run a model many times over and look at results from those many realizations of a model and sum them up. So a particular run of a model, for example, might secure for the number of low SES, low socioeconomic cases in that group compared to a high SES, we might see coming out of the model a very particular outcome for low SES and another one for high SES. In this case, high SES much lower than low SES cases, reflecting, say, greater crowding in the low SES. But if we run the model many times over, we may recognize that this outcome is just one of many possible ones. It just happened in that run. The number of low SES cases ended up here, and the number of high SES cases ended up somewhere in this region. But if we run it again and again and again and again, it induces distributions, empirically observed distributions in the number of low SES cases and high SES cases. And over time, we'd see some realizations with smaller number of cases by this time, some with larger, somewhere it never takes off, and both high and low SES are basically zero. Much, but certainly not all of the motivation for use of ABMs focuses on what if questions, and many of them reflect desire to evaluate interventions, counterfactuals, or we seek to undertake, ask the model, if we undertook this action, what would be the impacts? One of the most powerful things about ABMs in practice is they can be used to examine the effects of interventions that are longitudinal in character, depend on, for example, a person's history. So it treats them differently based on their history. Can be very targeted based on heterogeneity, based on geographic or network position, for example, focusing on core groups within STI networks, a key priority in STI prevention, for example. They can be triggered endogenously, based on conditions in the model, and conditions at any number of different levels of the model, and can be context dependent. Again, focus on addressing, for example, food deserts where they exist, or intervening in a network, building up network connections between people, as some of Alan Shields and Penny Hawes' early work pointed to, etc. And in fact, many interventions focused at a certain level on changing networks. So agent-based modeling's finer resolution supports looking at interventions at a much more detailed level, asking not merely where to intervene in a system, something that oft is insightfully pursued with aggregate models, but exactly how. And they can, although I won't comment on it further here, they can also be used to look at implementation science effects, issues of scalability and financial sustainability, the time to effect of interventions, and many other factors. Okay, so what are some advantages here of ABMs? Well, we can capture continuous and discrete and relational, in fact, heterogeneity very readily, and aspects of state that are in the same time, evolving networks, aspects of continuous state, someone's tolerance for opioids, for example, someone's level of antibody response, someone's level of toxic stress, or what have you. We can represent network and spatial context multi-level nesting, and multi-scale modeling. We can capture situated perception of individuals, learning over time and decision-making based on that perception, and do so with longitudinal information from the model that can be compared against comparable and very widely available, in some contexts, longitudinal information from the world. We can calibrate it against it. We can intervene based on this information. We can engage in storytelling for bringing in people with lived experience or policymakers using this information. Models are exceptionally powerful as storytelling vehicles when we can link it up to the experiences of individuals, for example, in the model, as well as the collectives. We can often specify interventions at a much more fine-grained level and reasonable amount of intervention implementation. We can use visualization to aid communication and intuition, and offer a capacity for in silico assessment of measures that we're interested in undertaking from the world And using our measures that we're intending to use for the world instead against an ABM, we can assess their blind spots. We can assess what they clue us into and what they don't, and address health equity concerns. So, here individual states are often discrete, not always. We can have continuous and relational states. But unlike aggregate stocks and flows, here we have multiple aspects of state we can readily keep track of, say multiple comorbid conditions or behavioral concerns. We don't have to consider that combinatorial explosion. We can keep track of how long someone is in a certain state, and aspects more broadly of their history. It's quite straightforward to build ABMs that feature multiple levels of context, a person within a neighborhood, a school, municipality, and country, for example. And an emergent behavior is often useful to examine across these different levels of scale. So we can have this nesting within the model that mirrors in a very natural way, far more so than when we're dealing with an aggregate model nesting in the world. I'm going to pass it over to my exceptional student, Wade McDonald, who has contributed some of the most exciting agent-based models that I've encountered in a long time, and we'll be describing two of them, one for chickenpox area and shingles, and the other for pertussis. So Wade, why don't you take it away?
Thank you. Apologies for the transfer between slide presenters here. I'm gonna review two agent-based models. The first represents chickenpox and shingles as examples. Chickenpox and shingles are two distinct diseases, both caused by the varicella-zoster virus. Chickenpox is typically a childhood disease, but once you've had this disease, the virus remains dormant in the body, and then it can reactivate later in life as shingles, which is often a debilitating and painful rash suffered by middle to senior aged adults. Our first question that we wanted to answer in building this ABM was, does vaccination for chickenpox cause increased shingles incidence? Immunity to the varicella-zoster virus is known to wane over time. Exposure to the virus later in life can boost natural immunity without causing clinical infection, but the degree to which this occurs is uncertain. This plays a role in shingles incidence as the level of immunity affects when it may reactivate and cause a shingles infection. In this model, as with all models, we have some features that are endogenous to the model, some are exogenous and specified by the modelers, and some are ignored as simplifying assumptions in order to construct the model. Endogenously, we represent transmission, contact patterns, mother-child dyads, vaccination schedule adherence, fertility, mortality, hospitalizations due to VZV infections, waning of disease-induced immunity, boosting of immunity, and accumulated costs. Exogenous to the model were assumptions about vaccine attitude, the specified vaccine schedule, and effectiveness of the vaccine, which was based on clinical research. Initial population demographics were specified exogenously, and as well as population density and unit costs for the various cost effectiveness analyses, which I'll discuss later. Ignored factors include household structure, time variation of contact structures, schools, and child care facilities. This state chart represents the natural history of disease for the varicella-zoster virus. So in the beginning, when a child is born, for a time, they are protected by maternal antibodies. They then become susceptible. These two states represent protection due to vaccination. With only one dose, it is possible to have a breakthrough infection while vaccinated, but once 2 doses are administered, a person is considered to be immune for life. So a person may go on to be weakly or fully infected with chickenpox. And then there is a period where they continue to show symptoms but are no longer infectious to others. Once they recover from chickenpox, this portion of the state chart represents the boosting of immunity effect due to possible exposure to other people with chickenpox. A shingles vaccination was implemented, although not used in the end in any of our scientific questions that we addressed with the model. And then the remaining states represent shingles infection, which can be present as a mild case or a severe case, which is called post-herpetic neuralgia. And then a person may recover from shingles and have a certain chance of relapsing. Life and death is handled by another state chart in this model. A person is alive for the duration of their lifetime. Certain events happen during their life, represented by these arrows within the alive state. This is an AnyLogic specific construct, but updates information periodically while they're alive. This transition here represents natural death not related to the varicella-zoster virus, and this transition on a message represents death due to the varicella-zoster virus, which is a very small but non-zero probability in the outcomes. A further state chart represents a person's adherence to the vaccination schedule. So when a person is young, too young to be vaccinated, they have no scheduled vaccines, they will become due for a first dose and either receive it or not, due for a second dose, receive it or not. If they receive the second dose but miss the first, they may get a catch-up. Heterogeneity is represented by these parallel state charts. All of the state charts I described previously were part of the person agent and describe different aspects of that person's state. This can be done with the charts in parallel without resulting in a combinatorial explosion of the number of states or compartments, as in compartmental modeling. Age is captured continuously in this model without coarse graining. This model was fit to empirical data in a couple of ways. First, we looked at chickenpox incidence in the pre-vaccination era and its distribution over age groups. Red represents our reference data from literature, and blue represents the model output. A similar comparison was done for shingles incidents. And again, red is the reference and blue is the model output. This flaring of the blue at the high age point is due to small populations as people reach nearly 100 years of age. So the emergent behavior we observed in this model was that answering the question that was posed initially, chickenpox vaccination is expected to cause an increase in shingles cases before it leads to an eventual decrease. What this plot is representing along the x-axis is time, and the y-axis is total shingles cases in the model. Vaccination begins at time 0, and this represents one realization of a baseline and another realization of the intervention case. So we can see once vaccination is introduced, the paths diverge and there is an increase in shingles incidence for a period of about 30 to 35 years, followed by a steep decrease. I mentioned that the strength of the boosting effect is still uncertain clinically. So we conducted a sensitivity analysis on this model by examining different strengths of boosting. In the upper left here, we have a small assumption about the strength of the boosting effect, and all the way to the bottom right where we have a large assumption. So it reveals another emergent behavior, which is that the degree to which shingles cases are expected to increase depends on assumptions about boosting of immunity. This model was further used to analyze some health economic questions, including costs about vaccine doses, costs for general practitioner and emergency department visits due to varicella-zoster virus, per day costs for people who were hospitalized, personal expenses, and productivity loss costs. Additionally, QALYs, which stands for quality adjusted life years and is a common measure in health economics, were accumulated in the model based on a person's accumulated time in various states. Such a accumulation is not easily possible in compartmental modeling due to the memoryless property of compartmental models. So the questions investigated, as I discussed in a fair amount of detail, the effect of chickenpox vaccination on shingles incidence, further an optimum in terms of quality of life measures, vaccination schedule for chickenpox within Canada. This is an example of a longitudinal intervention, which plays to the strengths of agent-based modeling. And the third analysis was the cost effectiveness of chickenpox vaccination with discounting. And again, this is a memory-full process, which plays to the strengths of agent-based modeling. The second example we'll look at today is a simulation model of pertussis, which was also developed using the agent-based methods with AnyLogic software. Pertussis, commonly known as whooping cough, is a bacterial respiratory infection transmitted by droplets in the air. It has a pathognomonic symptomology in children, meaning they develop a characteristic whooping sound as they gasp for breath after extended bouts of coughing. Infants are at high risk of serious and even lethal complications. 2/3 experience trouble breathing, half are hospitalized. Adults, by contrast, are often asymptomatic, have non-specific symptoms which may be confused with a cold or flu, but risk of complications rises with age, smoking, and pre-existing asthma or other respiratory conditions. A high rate of waning of immunity for this disease requires a course of 6 to 8 vaccinations to achieve full protection. Most people don't complete this entire course of vaccination. In Canada, the pre-vaccination era for pertussis was marked by multi-year cycles, traditionally infecting mostly children. Upon widespread vaccination, there were minimal outbreaks. Whole cell vaccine was the first vaccine developed, and it achieved high efficacy but had a higher risk of side effects compared to later developed vaccines. And there were also issues beginning as early as the 1970s and 80s with misinformation leading to vaccine hesitancy and reduced vaccine coverage. An acellular vaccine was introduced in the 1980s, and DTaP vaccine lowered side effects but also efficacy. Vaccination complacency and hesitancy flagged vaccination rates, and Canadian outbreaks began in the 2010s, concentrating in under-vaccinated adolescents. Infection spread could lead to transmission to infants, which is the primary risk group. In Alberta, which was the focus of our study, vaccination rates for doses 4+ are in the 70 to 80% range, but there's notable disparities in vaccination rates between families, schools, and communities. Notable outbreaks have occurred in the last 10 to 15 years, many in under-vaccinated adolescents who are clustered in vaccine hesitant or vaccine refusing communities. Examining the scope of this model, endogenously represented was transmission of pertussis, contact patterns, which we'll look at in more detail in a moment, schools and school transitions, household structure, household formation once a person reaches adulthood. Immune protection was represented as active and passive protection on a continuous state basis. Family vaccination adherence was considered. Vaccine catch-up for those who missed doses but remain accepting of vaccines. Fertility, mortality, differential case reporting based on the severity of infection, vaccine effectiveness, and the population preventable fraction, which is a measure related to vaccine effectiveness. Exogenously specified were vaccine attitudes, initial population demographics, hyperparameters for some distributions for other parameters, including vaccine attitude, immune memory types and waning rates, whole cell, acellular, and natural infection-induced immunity were represented distinctly. School structures were represented, and age-specific ascertainment rates for more serious infections were also specified exogenously. Ignored was household type change, contact structure during the day and at workplaces, interregional mixing, pertussis hospitalizations and mortality, and childcare venues. This figure represents the timeline of an agent over its life course, beginning with birth. Vaccination occurs at various points, mostly during childhood. That children enter school at 6 years and complete at 18 years. Between 18 and 28, they move out and form their own households and can become parents on their own up to 46. And then on average, 70 to 90 years is the life expectancy. Pregnancy and fertility is represented in an age and family structured specific fertility rate. So this state chart represents pregnancy, beginning with not pregnant, and then going through the trimesters and a post-birth period. The key being that the rate of this transition from not pregnant to the first trimester depends on a person's age and their number of previous children that they've already had. Demographics were informed by the census, the population pyramid of the initial population, distribution of household types, and distributions of couple and single households by the number of children in the household. Vaccine scheduling involved people being on schedule or non-compliant and have a possibility of switching between those states, depending the rates of which it depend on their vaccine attitude. This figure represents part of the fitting of the model. So this is vaccine coverage by dose along the x-axis. The darker columns represent the true state in Alberta, and the lighter columns represent what the model achieved. This figure represents the contact mechanism within the model. So for any given person, the yellow dot in this example, a person would be connected to all other people within a certain radius, which was the background contacts indicated in red. If a child, they would be connected to all other children at their school, and every person is associated with a household, and they're connected to all other people within their own household. This results in an emergent contact pattern as an emergent property of the model. This represents the part of the vaccine delivery course shown in to represent the continuous state of immune protection. So a person begins immune naive, and then the vertical steps are the doses, and the between dose periods are governed by an exponential decay, waning of immunity, and with 0 being the no immunity and 1 being maximum immunity. Immune memory was considered, which was represented by a 3-element vector, each associated with different decay rates based on the source of the immunity, be it a cellular vaccine, whole cell vaccine, or natural infection. Protection level was determined by this formula, the sum of passive and active protection components. Maternal immunity, which is called passive, decays at a rapid rate. Active immunity protection is determined by immune memory and decays according to a rate of the supporting immune memory. This figure represents the effect of maternal vaccination. In black represents, solid black represents the mother's immunity, and the dotted black line represents the child's immunity, as which decays rapidly following birth. The blue line, the solid line, represents the mother having a pre-birth vaccination during pregnancy, and then the decay rates apply, but from a higher point, leaving a higher protection level in the child for the first year of life. A person exposed with a certain force of infection in this model is carried in a message passed from an infected person to a susceptible. An exposed susceptible is infected with a probability pi if protection level lies below some threshold alpha I. Following infection, active protection is boosted to a maximum level and then begins to decay. Vaccination leads to active protection being boosted incrementally, as we viewed on a previous figure. For infants, the blunting hypothesis suggests that maternal immunization may lead to reduced immunity development by the early doses of the vaccine. And we'll say a bit more about that in a moment. These represent calibration matches. So the vaccine coverage, we viewed a figure of this in previously. We also matched to the average risk ratio since the last vaccination dose, mean yearly incidence, density of yearly incidence, autocorrelation of yearly incidence, and age distribution of pertussis incidence. The point of using these measures to fit the model was that we can't expect the model to match all of the ups and downs of an exact outbreak pattern necessarily. But the desire was to have outbreaks be in size and frequency that is expected based on data from the real world. This figure represents the emergent contact patterns from that contact structure described earlier. So for the most part, the diagonal represents people contacting other people of approximately their own age. The off diagonal areas represent child-parent contacts, and then some of these other outlying areas represent child-grandparent contacts. This was compared to Mossong et al. Study, also known as Polymods, done in Europe. The figure you're seeing is emergent output from this model, however. Scenarios run in the model were run for a time horizon of 50 years with a 20-year burn-in or warm-up period before maternal immunization began. The initial population was 500,000, but with births and deaths endogenous to the model, it would grow or shrink and not remain at exactly that value, sometimes called an open population. The baseline was with no vaccination. The main intervention was maternal immunization administered across 50% of pregnancies. A number of sensitivity analyses were examined, including different rates of maternal vaccination, alternative durations of immunity, varying ascertainment rates, blunting, and no passive protection from immunization. All scenarios were run for 30 realizations. This represents interventions retaining high effectiveness over a broad range of reporting threshold assumptions, which determines how severely infected a person must be to report their illness or have it reported as a case. This table represents the results. I think I may skip through these quickly, and a quick summary of the pertussis model's findings. In the age of falling vaccination rates, pertussis poses a danger to infants. Infant vulnerability to pertussis depends on both active and passive immunity. Rapid waning of pertussis immunity requires explicit consideration in models. There are many transmission routes to infants through homes, schools, and contacts with adults in their life and other children. Agent-based modeling provides a highly effective tool for evaluating the complex immunological dynamics associated with pertussis and social network contact. Maternal immunization is highly effective in reducing infant infections, and substantial benefits are provided by both cocooning and transfer of passive immunity. So I'll turn it back to Professor Osgood to discuss the limitations if we have time right now. Your sound isn't on, Professor.
Thank you. Thank you. But you can see the full screen here, except for this small box. Is that right?
Correct.
Okay. So I'm going to close this talk with some brief comments on limitations of agent-based models. All techniques have limitations, and agent-based models are no exception. Broadly, as an avid practitioner of multiple types of dynamic modeling, including aggregate models and individual-based models, both agent-based or individual-based, and in discrete event simulation, it's fair to say that aggregate models have frequently an edge in terms of faster construction and opportunities to calibrate, although with less flexible recourse to data. You can analyze them formally and work to understand them in ways that are often more immediate. They have lower baseline cost and involve much less programming, and their cost in terms of runtime, their performance cost, is invariant to the population size. The lack of stochastics means that you can run the model quite directly. And overall, the fact that you can build them more quickly and run them more quickly leaves more time for learning and refinement. By contrast, agent-based models provide us this exceptional tool for really understanding with greater reliability intervention trade-offs. We can represent those interventions that are contextualized, that are based on individual history, for example, individual position in networks or space. And we can examine interventions that are hardly targeted in ways that really are not readily addressable in any plausible fashion with aggregate models. We can calibrate and validate from longitudinal data, which is often a very important class of data for understanding dynamics, rather than the sort of evolving cross-sectional view given to us by aggregate models. We can capture heterogeneity, so key for concerns regarding equity issues and health disparities. And we can represent that heterogeneity in a more nimble way where we can add it in and sometimes may choose to change it or remove it even in a very facile fashion compared to the cumbersome, awkward, and quite error-prone process in aggregate models. Really, individual-based models are better for examining finer-grained consequences involving network spread and transfer effects and health equity concerns, concerns involving the spread over space, etc. And individual-based models, well, we might say aggregate models are often simpler. Some mechanisms can be simpler to describe in agent-based models. There are some key limitations, though. Explainability to non-modelers is currently a real challenge. In current state of the art, there's considerable programming required to build a medium and a lot for building a really large agent-based model. And there's no simple, crisp mathematical or graphical description and language corresponding, say, to ordinary differential equations or stochastic differential equations for aggregate models. It's all too easy to take the flexibility of agent-based models and run afoul of it by building models where too much is included too soon, rather than applying the Yagni principle. You ain't going to need it in building it up in an agile fashion bit by bit. Moreover, beyond the question we have with all types of dynamic modeling, seeking to address questions and characterize important types of factors within the world, there's beyond that basic issue of model validation. Have I built the right model? There's a question of, have I built the model right? Because of the level of programming involved, agent-based models often have a great deal of programming inside them, or at least a significant amount where bugs can lurk in today's approaches. We're working to address those with new generations of approaches, but that's the current state of the art. So agent-based modeling, in summary, is a powerful tool for investigate health-related questions, allowing us to represent individual history, targeted interventions, especially those clued off spatial and geographic context and network context. You can capture agent-environment interactions in rich ways with GIS and irregular spatial networks as well. Capture effects on networks and really richly capture heterogeneity. And all of these, and particularly the ability to capture heterogeneity, individual history, impacts of early life insults, adverse childhood experiences, are key for addressing needs on the health equity side. But key limitations: computational expense. A single realization can require a huge amount of computational need for a larger population, computational burden. And then there's typically a need to run it many times because of the need to have clarity that you're not dealing with flukes. You're dealing with an ensemble of realizations which are run to capture the regularities across many realizations. It requires significant programming, and there's no crisp mathematical description yet available. Critically, in this new age, it's not so much a matter of choosing one or the other, but really savvily weaving them together for effective hybrid modeling, combining types of models and using them in different areas of your modeling need to address different components of that need, and evolving the boundary between them in a savvy way. That lies outside this lecture, as do new advances towards declarative modeling. So I'd like to provide my most sincere thanks to those who made this work possible, including Canadian Immunization Research Network, our collaborators on this work, Alex Doroshenko, Karsten Hempel, Winchell Chen, and Alan Rafferty, and to Mathematics for Public Health for helping to sponsor these examples as a component of a book chapter. So thanks so much. We hope you've enjoyed this opportunity to learn about agent-based models, and we'll look forward to exposing you to additional types of agent-based modeling in coming lectures. Thanks so much, and take care.
Thank you.